Hello, I am Dr. Onkar Mittal and today I'll walk you through the essential guidelines for immunization practices. The practice of immunization begins with the healthcare professionals assessing the vaccination status of individuals, encompassing a series of meticulous steps that conclude with the vaccine's administration. Counseling of patients. The immunization process initiates with a critical counseling phase where healthcare providers inform patients about the specific disease and vaccine designed to prevent it. Some of the important points related to patient counseling are disease risk, prevention of statistical data to outline the probability of disease contraction within the population, highlighting that certain groups may face a higher risk of complications. Efficacy of vaccine. While acknowledging that no vaccine offers 100% protection, it is important to stress that most vaccines provide substantial defense against disease, ensure long-term immunity, and aid in preventing infection and its complications. Safety of vaccines. Advancement in vaccine production and testing technologies have significantly enhanced vaccine safety, making severe adverse reactions extremely rare. Consequently, the benefits of getting vaccinated greatly outweigh the potential risk of side effects. Cost considerations. Patients should be made aware that vaccine affordability is a consideration, yet all available vaccines are subject to stringent efficacy and safety evaluations before their market release. Ongoing recommendations. With an emphasis on adaptability of vaccine recommendations, which may evolve in response to new evidence or data, it is important to acknowledge that vaccine-specific recommendations may be updated as new information becomes available. Consent for vaccination. Consent is deemed given when individuals voluntarily present themselves for vaccination, having been thoroughly informed about the vaccine's benefits, risks, and associated costs. Injection procedure. Proper hand hygiene is crucial. Hands must be washed with soap and water for at least 2 minutes, following WHO's 6-step technique. Between patients, the use of an alcohol-based hand rub is advisable. The use of gloves is reserved for scenarios involving potential contact with infected bodily fluids or if the healthcare worker has open skin lesions. Sterile, disposable needles and syringes are mandatory, with a preference for auto-disposable syringes to ensure sterility. Each vaccine administration requires a fresh needle and syringe. Avoiding the mixing of vaccines unless specifically approved. When using multi-dose vials, it is imperative to clean the septum with alcohol before each withdrawal. Pre-filling syringes is discouraged to prevent errors given the similar appearance of many vaccines. Vaccines should be administered promptly after drawing from the vial and all sharp disposed of immediately in a secure container to prevent needle stick injuries and reuse. Mitigating vaccination-related pain and discomfort. To reduce the discomfort associated with vaccination, healthcare providers employ various strategies. Comforting measures like playing soothing music, engaging in distraction techniques such as encouraging deep breathing or visualizing pain being blown away have proven beneficial. Offering infants a small amount 2 ml of a 24% dextrose solution shortly before vaccination can have a calming effect. The use of vapocoolant sprays has been shown to provide short-term pain relief. Applying a 5% topical emulsion of lidocaine and prilocaine at least 30 minutes before vaccination can create superficial anesthesia, significantly reducing pain. However, the preemptive use of antipyretic medication is not advised. Route of administration and method. The method of vaccine administration determined by specific vaccine as outlined by the manufacturer to ensure the optimal immunological response. Deviating from the recommended route may compromise effectiveness of vaccine or may increase the risk of adverse reactions. Live vaccines are generally administered subcutaneously, while inactivated vaccines are usually given intramuscularly. For certain inactivated vaccines like hepatitis B, human papillomavirus (HPV), and rabies, the intramuscular route is essential. Incorrect administration via subcutaneous route necessitates a repeat dose. Conversely, for live attenuated vaccines such as measles, mumps, and rubella, varicella, and others, the route of administration is less critical and subcutaneous administration does not require dose repetition. Aspiration before injection is generally not recommended because of the absence of large blood vessels in the recommended sites, and the process may cause additional pain. If aspiration results in blood return, the procedure involves withdrawing the needle, discarding the syringe needle and vaccine dose in a sharp container, and preparing a new dose for administration to avoid vaccine wastage. Choosing an injection site carefully is vital to minimize the risk of neural, vascular, or tissue damage. Vaccines that include adjuvants to be administered intramuscularly to prevent skin discoloration, irritation, induration, inflammation, or granuloma formation that could occur if administered subcutaneously or intradermally. Multiple vaccinations. Administering multiple vaccines within a short time frame is a common practice in immunization protocols. It is important to understand that a variety of antigens can be given concurrently, though specific guidelines are in place to optimize the immune response and minimize adverse reactions. Guidelines for multiple vaccinations. Multiple antigens may be administered during the same visit, with exceptions and specific intervals to be observed for optimal efficacy and safety. For instance, PCV13 and Manactra should not be given together in case of functional or anatomic asplenia. A minimum of 4 weeks should separate their administration, with PCV13 preceding. Similarly, PCV13 and PPSV23 are not to be co-administered. PCV13 should be given first, followed by PPSV23 at least 8 weeks later. The standard interval between doses of an inactivated vaccine is set at 28 days. Vaccinations given up to 4 days before minimum age or interval requirement are generally considered valid, while doses administered more than 5 days early are not and should be repeated. This guideline is particularly pertinent for live parenteral vaccines. Combination vaccines. The use of combination vaccines, which include antigens not specifically indicated for the patient at the time of administration, may be considered under certain conditions. If the additional antigen poses no contraindication, if vaccines containing only the necessary antigens are unavailable, and if the potential benefits are more than risk of adverse reactions. Extra doses of many live virus vaccines as well as Hib and hepatitis B vaccines are generally safe, though additional doses of tetanus toxoid and PPSV23 may lead to increased local reactions. Co-administration with immunoglobulin preparations. When vaccines and immunoglobulin preparations are to be administered concurrently, they should be given at separate anatomical sites. If the same limb is used, vaccine should be administered at least 1 inch apart, preferably in the anterolateral thigh, with the vaccination site documented in the patient's record. Guidelines for spacing between vaccines and antibody containing products. The timing between the administration of vaccines and antibody containing products is crucial. If a vaccine is given first, the antibody may be administered at least 2 weeks later. Conversely, if an antibody is administered first, a minimum wait of 3 months is recommended before giving a live vaccine, with exception for monoclonal antibodies and specific cases such as rabies, tetanus, and hepatitis B, where vaccine and antibody can be administered together. Effective protection from a vaccine dose typically begins no sooner than 2 weeks post administration. A minimum interval of 4 months between priming and boosting is advised for the maturation of memory B cells, leading to more robust secondary responses. Brand interchangeability and vaccine scheduling. When vaccinating, it is advisable to maintain consistency with vaccine brands. However, if the initial brand is not known or is unavailable, substituting with an alternative brand is acceptable and should not delay vaccination. Interrupted schedule. Disruptions in the vaccination timetable do not necessitate restarting the vaccine series or adding extra doses. It is essential to rely on documented dated records as proof of vaccination. Documenting vaccinations. Accurate documentation is crucial for each vaccination, including the vaccine's brand name, lot number, vaccination date, and the administration site, e.g., right deltoid, left deltoid, right upper thigh, left upper thigh, right lower thigh, left lower thigh. Adverse reactions, prevention and management. Vaccine-related adverse events, also known as vaccine side effects, can also be classified as local, systemic, or allergic reactions, vary in frequency and severity. Local reactions like pain, swelling at the injection site are common side effects. Systemic reactions such as fever or malaise occur less frequently. Allergic reactions, though rare, can be severe. In adolescents, syncopal attacks are common and may cause injuries. Observing patient for at least 15 minutes post-vaccination or 30 minutes for those at higher allergy risk is recommended. Management of acute vaccine reactions. Prompt identification and treatment of anaphylactic reactions are critical for favorable health outcomes. Swiftly initiating appropriate medical response can avert severe events such as cardiac failure. Signs of such reactions may manifest as facial flushing, swelling, itchiness, and swelling around the mouth and throat, accompanied by wheezing and respiratory distress. It is imperative to position the patient flat on their back with their legs elevated. Epinephrine at a concentration of 1:1000 should be administered, can be repeated after 10 to 15 minutes. Ensuring the oxygen administration and airway maintenance is necessary. Immediate transportation to a medical facility for continued monitoring and care should be arranged. Vaccination contraindications. Chances of developing a serious adverse reaction can be increased with contraindications. In cases of contraindication to a specific medicine, administration of that vaccine must be avoided. As many contraindications are temporary, vaccines may be administered after some time. There are two types of contraindications. Absolute contraindication: patient must not be administered with concerned vaccine in these cases. A previous anaphylactic reaction to the same vaccine. 2. The development of encephalopathy within a week following a dose of a vaccine that includes pertussis without any other identifiable cause. 3. Rotavirus vaccine must not be given in severe combined immunodeficiency, and with the history of interception. Relative contraindications. Patients can be administered with vaccine when the contraindicating condition is no longer present, such as pregnancy and immunosuppression. Precautions. A precaution refers to a recipient's specific condition that could alleviate the likelihood of experiencing a severe adverse response, potentially complicate diagnosis, or hinder the vaccine's capacity to elicit an immune response. While it can lead to adverse effects, the risk of injury is generally lower than if a full contraindication were present. Certain conditions should be included with caution before administering vaccine, such as 1. The occurrence of a moderate to severe illness which may or may not be accompanied by fever. 2. A personal or familiar history of seizures, especially in relation to MMRV vaccine. 3. Recent administration of treatments containing antibodies. 4. A diagnosis of Guillain-Barré syndrome less than 6 weeks following a tetanus containing vaccine. 5. The consumption of aspirin or aspirin containing products prior to receiving the varicella vaccine. 6. The history of Arthus type allergic response subsequent to a diphtheria or tetanus toxoid vaccine, warranting a delay of at least 10 years before the next tetanus toxoid vaccine. 7. The presence of a progressive or unstable neurological condition, uncontrolled seizures, or progressive encephalopathy until the condition is stabilized and appropriate treatment is commenced. 8. History of low platelet counts, including thrombocytopenic purpura, is a concern when considering the MMR vaccine.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.